Good morning. Today we're going to discuss leukemias and lymphoma. So basically, this is the hematological PowerPoint related to oncology. Before we start into the different classifications of leukemias and lymphoma, let's remember the lineage of the hematopoietic stem cell. If you remember from pathophysiology, the lymphocyte lineage is going to give you the T lymphocytes and the B lymphocytes of plasma cells, those in charge mainly of antibody production. Then the myelocyte lineage is composed of erythrocytes, megakaryocytes, mast cells or basophils, eosinophils, neutrophils, and monocytes. The reason I put this slide is for you to remember that anytime you have an illness related to the lymphocyte lineage, for example, so whenever you have a disease, leukemia or lymphoma, that has alterations in the lymphocytes, you're going to see that the antibody formation as well as the T lymphocytes, the CD8 and CD4 counts will be diminished. On the contrary, if you have, for example, myelocytic leukemia, the myelocyte lineage is going to be affected, so the patient is going to have anemia. They might have thrombocytopenia or thrombocytosis. They might have alterations at the level of the immune system to recognize the antigen. They might have eosinopenia or eosinophilia. They might have neutrophilia or neutropenia. And as well, they might have alterations in neuronal and the phagocytosis. So let's go and do a little review on leukemia before we start on the proper classifications. Um, Leukemias are basically cancers of the WBC that involve the bone marrow, the circulating WBC, and organs such as spleen and lymphocytes, the lymph nodes. If you remember again in pathophysiology, you have the primary and the secondary lymphoid organs. Um, the primary lymphoid organ is the bone marrow, so this is the one that is mainly affected. But remember, in leukemias and lymphoma, you might also have alterations of the secondary lymphoid organs. Those secondary lymphoid organs are the ones that are in charge to produce antibodies and to participate in the inflammatory cascade and recognition of the antigens when the bone marrow is affected. And those are the spleens, so the patient might have splenomegaly and sequestration. They might have also lymphadenopathies. Risk for developing of leukemias in general, those patients that are exposed to any radiation therapy or any chemicals such as benzene, prior treatment with anti-neoplastic drugs, so any patient that is in cyclophosphamide or procarbazine or any type of chemotherapy is going to have the risk factors of having leukemia. Very important and very common infectious with virus, such as Epstein-Barr virus or any human T lymphotropic virus 1 or 2. Any chromosomal translocation, any pre-existing conditions such as immunodeficiency or patients that have chromosomal disorders such as Down syndrome or Fanconi anemia. Leukemias and lymphomas, they're malignant transformations that usually occurs at the pluripotential stem cell level, although it sometimes involves a committed stem cell with more limited capacity for differentiation. Abnormal proliferation with clonal expansion and diminished apoptosis occurs. Manifestations of leukemia are due to suppression of normal blood cell formation and organ infiltration by leukemic cell. Inhibitory factors that produced by leukemic cells and replacement of bone marrow space may also suppress normal hematopoiesis. That ensures anemia, thrombocytopenia, and granulocytopenia. There's organ infiltration that results in enlargement of the spleen, the lymph nodes, and also in addition to the liver. Occasionally, sometimes the kidney and is also involved, and there's also infiltration of the meninges. So these patients could also have increased intracranial pressure and also nerve pulse paralysis. The malignancies of the hematological system, again, it could be lymphoid, which are going to be discussed here today: lymphomas, lymphocytic leukemias, and multiple myelomas. Of the myeloid cell, you would have uh, acute myelocytic leukemia, chronic myelocytic leukemia, myelodysplastic syndrome, myeloproliferative disease, and polycythemia vera. Acute leukemia occurs when the hematopoietic cell undergoes malignant transformation into a primitive, undifferentiated cell. If you remember the lineage, you would have the formation of immature cells of the lymphocytes and myelocyte lineage, which are the blasts. So you're going to have a high proliferation of blasts in leukemias. That replaces normal bone marrow tissue, and the hematological cells induces anemia, thrombocytopenia, and granulocytopenia. In general, the symptoms that may be present for only days to weeks before diagnosis that basically disrupt the hematopoiesis, leads to anemia, infection, easy bruising, bleeding. Other symptoms that could be present could be pallor, fatigue, fever, malaise, weight loss, tachycardia, and even chest pain due to hypermetabolic state. The cause of fever most of the time is not found, although granulocytopenia may lead to a rapidly progressing and potentially life-threatening bacterial infection. Bleeding is usually manifested by petechia, easy bruising, epistaxis, bleeding gums, or menstrual irregularity. In addition, patients could have hematuria and GI bleeds. Bone marrows and periosseous infiltration may also cause bone pain, joint pain. In addition, patients could have involvement of the central nervous system uh, with leukemic meningitis that would give the patient headache, vomiting, irritability, nerve palsies, seizures, and even papilledema. Extramedullary infiltration could also occur. Patients would have alteration in the secondary lymphoid organs, and they would have lymphadenopathies, splenomegaly, hepatomegaly, and even a rash, which is called leukemic cutis. Acute myeloid leukemia is the first that we will discuss. Is again a malignant transformation and uncontrolled proliferation of abnormally differentiated long-lived myeloid progenitor. Remember that when you have myeloid progenitor, if we come here, the patient is going to have erythrocytes alteration, platelets alteration, mastocytes, eosinophils, neutrophils, and monocytes or dendritic cells. So these patients are going to have most of the time anemia, thrombocytopenia, leukopenia, um, and poor recognition of the antigen when patients are exposed to any secondary um, infection, opportunistic. So the symptoms it will include fatigue, pallor, easy bruising, bleeding, fever, infection, and any other extramedullary infiltration as well, as we mentioned. It's very common in men more than 65 years old, European descendant, even though it could occur in Hispanic or Latino background. Um, Often there's no direct cause that can be found. um, the bone marrow that normally produces red cells, white cells, and platelets are the ones that are affected. AML causes the bone marrow to have hyperproliferation of immature white blood cells, which are called blasts. So when you do a peripheral smear, you're going to see the presence of blasts. There is, as I mentioned before, anemia, leukopenia, thrombocytopenia, because the lineage that is affected is the myeloid. So you're going to have anemia, you're going to have thrombocytopenia, you would have alterations in recognition, you would have eosinopenia, neutrophilia, or neutropenia. Okay, it's basically acquired from, or it could be genetic as well. AML has a number of subtypes that are distinguished from each other by morphology. You could see myeloid, myeloid monocytic, monocytic, erythroid, and megakaryocytic. Increases with age, the incidence, and it is more common um, in male. The median onset of age is 50 years old, and may occur as a secondary cancer after chemotherapy or radiation therapy. Remission induction rates ranges from 50 to 85, and survival could occur like 20 to 40%. The prognostic factors before we go into the symptoms help determine treatment protocol and intensity. Patients with strongly negative prognostic features are usually given more intense forms of therapy. An important prognostic factor is the leukemia cell karyotype. So if you do a genetic study, the presence of leukemic cell karyotype, for example, cytogenic findings of T gene 8 and 21 or T15 and 16, those are poor prognostic factors. Patients with a normal karyotype have an intermediate prognosis. And patients with a poor prognosis are those with deletions of chromosome in chromosome 5, 7, trisomy 8, etc. The symptoms, basically, if you concentrate on the myelocyte lineage, they're going to have anemia, leukocytosis or leukopenia, and thrombocytopenia. And general symptoms that could occur in all of them is fatigue, shortness of breath from the anemia component, easy bruising from the thrombocytopenia, bleeding, prolonged bleeding with minor cuts, recurrent minor infections and poor healing due to neutropenia and opportunistic infections, loss of appetite and weight loss due to catabolism, organomegaly, and lymphadenopathies, meaning liver, splenomegaly, hepatomegaly, and lymphadenopathy, because all the secondary lymph organs are participating in the production of and substituting bone marrow for its failure. In addition, the infiltrates in bones, producing bone pains. Patients could present with gingival infiltration, so the infiltration of myelocytes could occur at the level of the bone marrow and at the level of the secondary lymph organs and extramedullary as well. Patients could present with petechia or purpura as a sign of thrombocytopenia. In addition to that, patients could have infiltration of myeloid cells, immature, at the level of the bone, producing a tumor. Risk factors, as we already discussed, genetic disorders such as Down syndrome and Fanconi anemia. Patients are most commonly, as the age is more frequent in AML, more than 50 years of age. Smoking in 20% of cases, that doubles the risk. High doses of radiation therapy or chemotherapy, presence and exposure of pesticides and herbicides, and exposure of chemicals such as benzene. This actually applies, these risk factors apply for all of them. Diagnosis is basically done by the presence of more than 30% of immature cells in a bone marrow aspirate, which is 30% or more. So we're going to discuss the FAB criteria and the WHO criteria as well. So basically the presence of blasts at the level of the peripheral smear. They should not be present because those are immature cells. If we go to the FAB criteria, which is more than 30% blast, basically is you have myelocyte at the level of 0. So uh, basically you have undifferentiated acute myeloblastic leukemia is 5%. M1, there is the AML with minimal maturation, so you have 20% of immature cells only and the rest are mature. Uh, M2 is basically with maturation of 30%, and here you have already chromosomal malformations that it will give you a poor prognostic factor. M3, acute promyelocytic leukemia, 5% of mature only. M4, acute myelomonocytic leukemia, which is 20%, and so on, up to acute megakardioblastic anemia that includes all the myelocyte lineage. The higher you go, the poorer the prognosis, and the higher the chromosomal abnormality involvement. If we go by the WHO classification, the first grade is with certain genetic abnormality and chromosomal abnormalities, will give a really bad prognosis. AML with multilineage dysplasia, so many of the lineage, including lymphoblastic, is also involved. AML related to prior chemotherapy or radiation. AML no otherwise specified as we have in FAT classification. And undifferentiated and biphenotype acute leukemia. So again, if you have 30% of blasts by FAT criteria, which you're going to be in M2, or if you have more than 20% blast on bone marrow aspirate, that basically you're going to be at the level of M2 as well in AML, not otherwise specified. Okay, the treatment is basically chemotherapy by induction or consolidation, and sometimes stem cell transplantation. Induction therapy is phase 1, and phase 2 will be remission continuation therapy or consolidation. You could do radiation therapy for certain cases or bone marrow transplantation. What is the induction therapy? Initial therapy attempts to induce remission and differs from ALL in that AML responds to fewer drugs. So you need less drugs to treat AML. The basic induction regimen includes, for example, cytarabine by continuous IV infusion, or daunorubicin or idarubicin. In addition, you could give etoposide or vincristine or prednisone. Treatments usually result in significant myelosuppression with infection or bleeding. There is significant latency before bone marrow recovery. Consolidation therapy after remission. Many regimens involve a phase of intensification with the same drug used for induction. For example, you could use cytarabine in induction therapy, for example, by IV infusion or high dosages for 5 to 7 days. And if you could use the same medication at high dose, regimens may lessen remission duration, particularly when given for consolidation in patients less than 60 years of age. CNS prophylaxis usually is not given to adult patients because with better systemic disease control, CNS leukemia is a less frequent complication. Relapse, patients who have not responded to treatment and younger patients who are in remission but who are at risk of relapse. may be given high-dose chemotherapy and stem cell transplantation. Extramedullary sites are infrequently involved in isolated relapse. When relapse occurs, additional chemotherapy for patients unable to undergo stem cell transplantation is less effective and often is also poorly tolerated. Another course of chemotherapy is most effective in younger patients and in patients whose initial remission lasted less than a year. So basically, the key point for AML is the most common acute leukemia in adult. There are a number of subtypes. Chromosomal abnormalities are common and have implication of poor prognosis. Chemotherapy often prolongs survival, and stem cell transplantation may help patients who do not respond to treatment and younger patients as well. Okay, so you could do remission and induction with the medication that I already mentioned. You could do post-remission therapy with the same medication, a high dose, or maintenance with the same chemotherapy for 4 to 12 months. In addition, your goal for completing remission is that you must have platelets greater than 100, neutrophil counts greater than 1,000, and bone marrow with 5% of less blast. There is molecular complete remission when there is no evidence of leukemic cells in bone marrow. You could do this by flow cytometry or protein chain reaction. If in complete remission for 3 years or more without relapse, the patient could be considered potentially cured. Now let's talk about CML. CML is chronic myelogenous leukemia. Um, Occurs when the pluripotential stem cell undergoes malignant transformation and clonal myeloproliferation. That leads to a striking overproduction of immature granulocytes. It's initially asymptomatic. Progression is very insidious when no specific benign stage. Patients could complain of malaise, anorexia, weight loss, so the symptoms are not specific for the disease. Eventually, this could give way to accelerated or blast phases with more ominous signs. Patients could have bleeding, fever, lymphadenopathies, pallor, easy bruising, splenomegaly, and even skin changes. The pathophysiology of CML, most cases of CML appears to be induced by a translocation known as Philadelphia chromosome. So this is very important, that actually is a marker of CML. When this is present, is 95% of the patients would have for sure the diagnosis of CML. The fusion of BCR and ABL, which is a chromosome translocation, is also present. Is also a molecular hallmark, and is a causative of initiation of the event of CML. So basically, there's a fusion of gene BCR and ABL. It is important in the pathogenesis and expression of CML. And this results in the production of specific tyrosine kinase. CML ensues when an abnormal pluripotential hematopoietic progenitor cell initiates an excessive production of granulocytes, primarily in the bone marrow, but also could occur in extramedullary sites, in the spleen, lymphocytes, lymph nodes, liver. Although granulocyte production predominates, the neoplastic clone includes also RBCs, megakaryocytes, monocytes, as we explained before in the lineage. Diagnosis, peripheral blood smear, basically by bone marrow aspirate as well, and demonstration of Philadelphia chromosome. 7% to 50% of all adult leukemias have CML, and the median age at diagnosis is 55 years old. So patients that are greater than 55 or 50 years old are exposed to this type of chronic leukemias. Okay, so the pathophysiology we already explained a little bit. Um, Disorders of the stem cell in the bone marrow that basically is the inflammatory cascade trying to um, recognize the antigen and fight the infection. So therefore, there is the alterations of granulocyte, monocytes, and neutrophils. Therefore, patients would have um, overproduction because the bone marrow and also secondary lymphoid organs are affected. The overproduction of immature cells, which are called blasts. There are also genetic mutations, as previously stated, in the chromosome 9 and 22 with reciprocal translocation, in which a piece of chromosome 9 containing the oncogene CABL is translocated to chromosome 22. This, as previously stated, will produce an unregulated tyrosine kinase and production of immature granulocytes. The adaptive immune system tries to repair um, the programmed cell death, which is apoptosis, but there is also alteration of apoptosis at this level, the same as the prior classification. 80% of patients diagnosed with CML have um, the Philadelphia chromosome. Actually, in the literature, in the guidelines, it's over 95%. Only 5% have Philadelphia chromosome negative. As previously stated, also, the majority of patients initially are asymptomatic, and if they do have symptoms at the beginning are very vague and because the progression is very insidious. So all the symptoms are general like malaise, anorexia, weight loss. Patients could have left upper quadrant discomfort due to splenomegaly. And then as it goes, patients start having more specific symptoms of blast crisis, which are the splenomegaly, easy bruising, bleeding, lymphadenopathy, and skin changes. The presence of ABL, BCR gene translocation, and presence of chromosomal Philadelphia. Diagnosis is basically due by CVC and peripheral smear, bone marrow examination, and cytogenetic studies with the presence of Philadelphia chromosome. But usually it's done by accident. Patients that would have leukocytosis or leukopenia. Most of the time they come in with leukocytosis super elevated out of the extraordinary on a patient that is completely asymptomatic. So this is a walkie-talkie patient with a leukocytosis of 30,000 or 40,000 or more without any other symptom. In addition, patients could complain of constitutional symptoms not related to the illness. They could have lethargy, weight loss, or anorexia. Um, they could have secondary lympho organs alterations such as splenomegaly, hepatomegaly, and lymphadenopathies. The diagnosis CML is more frequently diagnosed by a CBC obtained incidentally or during evaluation of a splenomegaly. Granulocytes would be elevated, usually in the 50,000s or a little less, in asymptomatic patients and 200,000 and even a million in symptomatic patients. Platelet counts could be normal or moderately increased. Um, Hemoglobin could be usually more than 10 grams per deciliter. Peripheral smear may help differentiate CML from leukocytosis of other etiologies. In CML, peripheral smear frequently shows immature granulocytes, as well as eosinophilia and basidophilia. In patients with a WBC of less than 50,000, immature granulocytes may not be seen, but leukocytosis could be present. Leukemoid reactions resulting from cancer or infection um, are not associated with eosinophilia or bacillophilia. Diagnosis is confirmed by finding the Philadelphia chromosome in samples of cytogenetic. Um, During the accelerated phase of disease, anemia and thrombocytopenia usually develops. There are many stages of CML. Patients could have chronic phase um, or accelerated phase and blastic phase, which is called also blast crisis. This one is very important because the prognosis is very poor. Um, Even though it has improved for the last 2 months, and the survival also has increased due to the usage of newer drugs or chemotherapy. Basically, patients would have fulminant symptoms of the disease and multiple organ involvement. 20 to 30% of more granulocytes in bone marrows are present. Treatment, if you remember the pathophysiology, the formation of tyrosine kinase, so basically the patients would have tyrosine kinase inhibitors to try to contain the alterations of BCR and ABL gene production. So the old standard treatment was hydroxyurea, interferon alpha, and cytarabine, and the new ones is basically targeting the pathophysiology of the disease. So except with stem cell transplantation, treatment is not known to be curative. However, when tyrosine kinase inhibitors are used, survival is prolonged and maximum overall survival has not been reached. From tyrosine kinase inhibitors, you could use hymatibine. You could also use decitabine or nilotinib. In addition, you could use, for example, dasatinib or nilotinib. Those are tyrosine kinase inhibitors are dramatically effective in achieving complete clinically and cytogenic of Philadelphia chromosome remission. Hydroxyurea was the older chemotherapy. Those are reserved for BCR and ABL negative patients. Patients will relapse after receiving tyrosine kinase inhibitors. And in patients that have a blast crisis as well, you could use hydroxyurea. Here is basically to explain the mechanism of action, okay, that we already discussed in the pathogenesis. Okay, you have the first generation thyroid kinase inhibitor, which is hymatinib. This is the most commonly used. Okay, and the main side effects that you have to remember is fluid retention or dehydration at the same time from diarrhea. Patients could have bone pain from sequestration. You could have muscle cramps, neutropenia, thrombocytopenia. If the patient is resistant to hymatinib, you could use the second generation. You could use dasatinib or nilotinib. Um, so basically, the side effects are exactly the same. You have to look for fluid retention as well as dehydration due to diarrhea and vomiting, myelosuppression, and you could also use the second generation of nilotinib, which is the other medication. So basically, you start with hymatinib, okay, and you monitor the cytogenic formation uh, of Philadelphia chromosome and also the BCR-ABL every 6 to 12 months. If the patient has a very good response, you just continue checking the PCR every 3 to 6 months. If the patient has suboptimal results or a resistance to imatinib, you go to the second generation that we already mentioned, and basically, if it's failure, then transplantation. So what is the actual hematological response? That the patient will have decrease in WBC, because remember they come in with granulocytosis of more than 50,000, granulocytes from 10 to 4%, clinical signs of improvement, and cytogenic response is when there is elimination of the Philadelphia chromosome by FISH or PCR. Now let's talk about CLL. And CLL is the chronic lymphocytic leukemia. Is basically the most common of the chronic lymphocytic leukemia in the Western world. Involve mature appearing defective neoplastic lymphocytes, almost always B cells, with an abnormally long lifespan. The peripheral blood smear, bone marrow, spleen, and lymph nodes are infiltrated. The peak is between 60 to 80 years old and is characterized by the presence of lymphocytes, more common in male than female, and it could also be discovered incidentally. There is basically lymphadenopathy, anemia, splenomegaly, and hepatomegaly, the same as the others. There is opportunistic infections and thrombocytopenia. In about 98% of cases, CD4 and CD5 B cells undergo malignant transformation, with lymphocytes initially accumulating in the bone marrow and then spreading to lymph nodes and other lymphoid tissues such as splenomegaly and hepatomegaly. As CLL progresses, abnormal hematogenesis results in anemia, neutropenia, thrombocytopenia, and decreased immunoglobulin production, because remember, it's mainly for the B cell, for the production of antibodies. So these patients would have hypogammaglobulinemia and impaired antibody response. So patients would have all the symptoms already mentioned. Okay, so leukocytosis, lymphocytosis, anemia, normocytic normochromic type, thrombocytopenia could also occur. Uh, in 70 to 90% of patients, they would have mature lymphocytes, and basically B lymphocytes are the ones that are affected. Um, is confirmed by examining the peripheral smear and bone marrow. The hallmark is sustained absolute peripheral lymphocytosis. So these patients would have more than 5,000 units per liter of lymphocytes, and increased lymphocytes more than 30% in the bone marrow. In addition, you could do immunoglobulin electrophoresis, and they would have decreased IgG. In addition, patients would have chromosome abnormalities, mostly involving trisomy 14 and deletion of the 12. There are many classifications for CLL. You could have pro-lymphocytic leukemia, leukemic phase of cutaneous T-cell lymphoma, hairy cell leukemia, and lymphoma progressing to leukemia. So basically, stage 0 is absolute lymphocytosis of more than 15,000. Stage 1 is stage 0, this absolute lymphocytosis plus lymphadenopathies. Stage 2 is stage 0, which absolute lymphocytosis with splenomegaly and or hepatomegaly and or lymphadenopathy. Stage 3 is the absolute lymphocytosis plus anemia plus any organomegaly or lymphadenopathies. And stage 4 is all of them, with including the myelocyte lineage as well, involvement. There's another classification, which is basically there is the organomegaly in 0, 1, or 2 areas with no involvement of the myelocyte lineage, 30% of involvement of more than 5 areas, and there is the hemoglobin more than 10 and thrombocytosis, and stage C, which is less than 20% involvement of organomegaly with the same values for the myelocytic lineage. Cure is rare. These patients tend to be symptomatic. Um, so basically, symptom amelioration and supportive care is the best for CLL because it's progressive. Some patients may be asymptomatic for years. Therapy is not indicated until progression or symptoms occur. Um, Supportive care includes transfusion of white red blood cells and erythropoietin injections, platelet transfusion, and antimicrobial therapy. In addition, of course, you could give chemotherapy, corticosteroids, monoclonal antibody therapy, and radiation therapy. So again, let's review the stages. You have stage 0, which you have absolute lymphocytosis of more than 15,000 in blood and more than 30% of lymphocytes in the bone marrow. Stage 1, you have the stage 0 plus enlarged lymph nodes. Stage 2, stage 0 plus hepatomegaly or splenomegaly. Stage 3, this is stage 0 plus anemia with hemoglobin less than 11. And of course, organomegaly and lymphadenopathies. And stage 4, you have the stage 0 plus thrombocytopenia with platelets less than 100,000. And BNET, again, stage A, you have absolute lymphocytosis of more than 10,000 and more than 30% lymphocytes in the bone marrow, the same as stage 0. And hemoglobin more than 10, platelets more than 100,000, and less than 2 involved sites. Stage B as stage A, but 3 to 5 involved sites and compromise of myelocyte lineage. You have hemoglobin more than 10 and platelets more than 100,000. Stage C, you are like stage A and B, but the hemoglobin already drops less than 10 and the platelets are less than 100,000. So as you progress, it's worse. So you could do different modalities. You could do chemotherapy with chlorambucil alone or with corticosteroids. You could also do fludarabine, which is more effective. You could do combination chemotherapy with fludarabine, cyclophosphamide, and rituximab. More often induces complete remission. You could also do corticosteroids. You could do prednisone 1 milligram per kilo. You could do radiotherapy. You could do monoclonal antibody with the use, for example, of rituximab. This is the first monoclonal antibody used in the successful treatment of lymphoid cancers. You could also use others such as alemtuzumab and fludarabine, etc. Splenomegaly is basically for immune-mediated cytopenia or pain or sequestration. You could also do immunoglobulin replacement for patients that are gamma globulinemia. Now let's talk about lymphomas. And lymphomas are basically a heterogeneous group of tumor arising in the reticular endothelial and lymphatic system. You have major types of lymphoma, which are Hodgkin lymphoma, non-Hodgkin lymphoma, and Burkitt lymphoma. They're 4% of all cancers, and they're mostly solid tumors. Again, if you remember, you have these are the lymphomas, and from the B cell or the T cells. 70% are non-Hodgkin lymphoma. So the most common is the non-Hodgkin lymphoma. The incidence is 56,000 cases per year. Lymphomas were once thought to be absolutely distinct from leukemia. However, better understanding of cell markers and tools with which to evaluate those markers now show that there is a distinction between the two cancers. So you have nodal involvement, You have extra nodal involvement as well. We're going to go through the stages and histological classification. Um, Nowadays, they have a better prognosis. Um, so patients that have 4% of all the cancers have poor prognosis as well as HIV. 80% again are B cells and 15% are T cells. Viruses that are involved in the production of lymphoma are adult T cell virus, Burkitt for Epstein-Barr virus, HIV, patients that have Kaposi sarcoma, and even Helicobacter pylori for mild lymphoma. They also, as well as the leukemia, they have chromosomal translocation, for example, in the 8 and the 14 level for the Burkitt lymphoma, and for the 14 and 18 for non-Hodgkin lymphoma. Etiology, the majority of lymphomas have genetic and environmental factors as well, even though it's very contradicting. The same as leukemia, any farmer exposed to pesticides or herbicides, Benson, any chemotherapy in the past. Okay, you have the WHO classification for Hodgkin lymphomas and non-Hodgkin lymphomas. You have the B cell neoplasm and the T cells and natural killer cells lymphomas. We're going to study here today. You have, for example, the B cells precursors, which are the lymphomas and the ALL. You have the mature B cells neoplasm, which you have already discussed, the CLL. Today we're going to talk about lymphomas. Um, in addition, you have the precursor T cells, which are also lymphomas and leukemias. The clinical presentation of lymphomas basically are indolent. The majority appear with a lymphadenopathy, visible or not. You have patients that come in with lymphadenopathies or splenomegaly, aggressive type. Patients could present with an enlarging mass in the nodal area. So, for example, they could come with cervical lymphadenopathy without pain, without any other symptom, or associated with hepatomegaly, GI discomfort, and also the lineage that could be affected with lymphocytosis or lymphopenia, um, and night sweats and fever, etc. So basically, the diagnosis is done by history and physical. You could do laboratories to basically determine the, if there's presence of leukocytosis or leukopenia, or the presence of any type of infection. Lactate will be elevated if what actually triggered the disease process was the infectious process, or because it was an opportunistic infection. The most relevant diagnosis is done by biopsy of the nodule. Um, you could also do CT scan of the chest or abdomen and pelvis to determine the extension and classification. PET scans, bone marrow biopsy, which as well as the lymph node biopsy is the most accurate. You could also do lumbar puncture to be able to determine complications or involvement of the CNS by lymphoma. Now, before we go into details of both classifications, let's talk, and this is very important for you to know, the Ann Arbor staging system. So basically, when you suspect a patient that have lymphoma, or you diagnosed accurately by biopsy, you want to determine the stage of the disease. So stage 1 is there's one lymph node in the same site and there's no extranodal involvement. For example, if the patient comes in with a cervical lymphadenopathy above the diaphragm, and in the same site, only one is a stage 1. So if you have stage 2, is 2 or more lymphadenopathies. in the same side of the diaphragm. For example, if you have a lymphadenopathy in the cervical area only, it's stage 1. If you have a lymphadenopathy in the cervical area and also one in the mediastinum that's above the diaphragm in the same side, then you have stage 2. If you have involvement above or below the diaphragm, for example, if you have one node in the cervical area and one node is in the pubic area, that's the stage 3. And if you have this diffuse or disseminated involvement of one or more extra lymphatic tissue or organs, it's stage 4. This is basically metastasis. Okay, so again, stage 1, this is only one lymph node. This is stage 2 because you have two lymph nodes but above the diaphragm and on the same side. This is stage 3 because it doesn't really matter how many lymph nodes you have above and below the diaphragm. And if you now have involvement of extra organ, like secondary lymphoid organs and also pelvic lymphadenopathies, so you have more spread of the disease, you have stage 4. Okay, you have risk factors that could be associated that also have to do with the prognosis. These are the main risk factors. Age is greater than 60, serum lactate elevated, the unharbored when you have 3 or 4 classification, if the hemoglobin is less than 12, or there is involvement of more than 4 lymph nodes. So if the patient has 0 to 1, is a low risk factor, and look at the survival. And the more involvement, the less survival. Treatment for lymphoma is basically radiation therapy for stage 1 and 2. Chemotherapy for stage 2 and bone marrow transplant is the only curative of the disease. But let's talk briefly before we finished between the difference between Hodgkin and non-Hodgkin. Hodgkin is a localized or disseminated malignant proliferation of cells. Hodgkin lymphoma results from clonal transformation of cells of B cell origin that gives rise to Riedt-Steinberg cells. So the Hodgkin lymphoma are mainly characterized by Riedt-Steinberg cell, the same as CML for the Philadelphia chromosome. Okay? So the causes are exactly the same. It could be woodworking, it could be exposure to radiation, chemotherapy, exposure to the Epstein-Barr virus, the HIV, the TB. The symptoms, as we discussed, you could have fever, night sweats, unintentional weight loss. You could have involvement of all the organs. You could have jaundice, leg edema, dyspnea, wheezing, and even cavitations. Okay, the diagnosis, again, you could do a chest x-ray and CT scan of the chest or abdomen and pelvis to determine the extension. You could do CVC. You could do biopsy that basically reveals the Riedt-Steinberg cells. Okay, and also the non-Hodgkin lymphoma. Basically, the etiology is exactly the same. Most 80 to 85% arise from the B cell, so the remainder arise from the T cell or natural killer cells. Those are precursors or mature cells that are involved. Patients would have, in the classification of non-Hodgkin, you would have precursor B cells and mature B cells. Many patients present with asymptomatic or peripheral lymphadenopathy. So basically, it's a lymph node that doesn't hurt. Enlarged lymph nodes are rubbery, discrete, and later become matte. They could also have involvement of the bone. They could have anemia. The diagnosis is exactly the same. We went through the staging system. Prognosis, patients with a T cell lymphoma generally have a worse prognosis than those with B cell lymphoma. So survival also varies by factors that we already discussed. You know, if the age is greater than 60, if they have elevated LDH, if they have stage 3 or 4. Okay, and the treatment, again, we already went through that. So this is the end of this presentation.